I'm going to invite Crystal Suarez, one of our chief residents, up to introduce this lectureship and today's speaker. Thank you.
Good morning, everyone. My name is Crystal, and I'm one of the pediatric chief residents. Every year, we remember Rudene Marie with this lecture in her honor, dedicated to exploring the topic of compassionate patient care. And so we'll go ahead and share this video with comments from those who knew her.
We really think it's remarkable that after nearly 30 years from her death, those who knew Rudene continue to be inspired by her life and carry her lessons about patient care with them into our work. Some here were fortunate enough to know Rudene, but for those who did not, who was Rudene and why did she inspire such devotion to keeping her memory alive? To answer this, we should give you a bit of history. Rudene was diagnosed with chronic myelogenous leukemia when she donated blood just a few weeks before she graduated from Tulane Medical School. This was a time before the lovely tyrosine kinase inhibitors were on the market. And really, this was a death sentence for Rudene. Nevertheless, she started her internship and residency here at Stanford full of vim, vigor, and cheer, choosing not to burden her coworkers with her diagnosis. She wanted to achieve what she did on her own abilities with no special treatment. Initially, she told very few people of her illness. In fact, when she had her first bone marrow transplant during residency, very few people even knew that it happened. What they did know was that an amazingly bright and capable physician, as well as a total team player, was Rudene. Remarkably, she returned 2 clinical rotations after her bone marrow transplant. When it was apparent that the transplant had failed to cure her, she then courageously underwent a second transplant. She was so determined to complete her training, she did so shortly before she succumbed to her disease. Her colleagues and friends and family started this lectureship and meet each year to remember Rudene and to perpetuate the lessons that she taught us about compassion for others during her own illness. We all have different stories about Rudene's impact on us. She was the consummate hostess in a sense. She was fun to be with and always made everyone around her feel comfortable and cared for. She would not expect others to feel sorry for her, often reciting her favorite quote from the Forrest Gump movie, "Life is like a box of chocolates because you never know what you're going to get." We thought the best way to give a sense of why Rudene continues to inspire us and those who knew her would just to be sharing a couple of vignettes about the sense of who Rudene was.
So this is a story that illustrates Rudene's selfless compassion and was told to me recently by her attending when Rudene was an intern on the pulmonary service. In that era, patients with cystic fibrosis were admitted to Children's Hospital long after they were adults, sometimes well into their 20s or 30s or even older. And this was not exactly the stuff of pediatrics. And many residents felt that, well, this wasn't really contributing to their training to become pediatricians. So one day the team learned that an adult patient that they knew well was being admitted. This person was much older than any of them and was famously irascible and difficult. So no one wanted the assignment of doing the history and physical. So Rudene cheerfully volunteered. And when she presented her findings to her attending, her initial remarks were to the effect of, "What a nice man and such an interesting case." And in the words of her attending, Rudene saw this as an opportunity to provide compassionate care to a very ill and fragile fellow human being, not as an annoying imposition. And as powerful as this vignette is as an illustration of Rudene's grace and compassion, to me it's remarkable that 30 years after this event, her attending still remembers it. And to me, that's a just remarkable testament to Rudene's supreme gift to us as a role model that lasted forever.
I will never forget Rudene shortly before she died. She was in the hospital at Stanford for quite a long time, and she gave us several imperatives to live with. One day she asked me, "Why am I still here? How come I haven't died yet?" It was just she and I. And I answered that perhaps her mission with us was not done. In response, she thought about the things that make a physician better from the perspective of a patient. She simply replied, very simple things really. Sit down when you talk to parents and patients. Wear a name tag and introduce yourself. Involve the patient in decision-making. Keep promises. Patients remember. Never underestimate the importance of touching your patients.
And so we honor and remember Rudene for her gift to us, an enduring role model for compassion despite her own illness, while giving us a window into the world of being a patient.
We're grateful to have been able to hear about Rudene Marie and her legacy from her friends in this video. It is now my pleasure to introduce our speaker for this year, Dr. Tasha Faruqui. Dr. Faruqui is a pediatrician, a speaker, author, and advocate. Inspired by her father, a doctor to an underserved rural community, Dr. Faruqui joined the National Health Service course after medical school. Her focus shifted when her daughter Soraya was born with a rare medical condition that remains undiagnosed. Today, Dr. Faruqui is a passionate advocate for parents of medically complex children and those experiencing anticipatory grief. She regularly brings her dynamic message of fierce and loving hope to Make-A-Wish fundraising events, Cincinnati Children's Hospital, an online community, and many other places and people around the country, transforming even the most personal experiences into a universally relatable message. We are incredibly grateful for the opportunity to hear from Dr. Faruqui and the story of her family, her husband Safi, and 3 daughters, Lena, Soraya, and Yasmin. In Rudene Marie's honor, please join me in welcoming Dr. Faruqui.
Thank you, everyone. I want to start by first starting with gratitude. I think many times we save the thank yous for the end, but I want to really remember why I'm here, and it's truly because of Rudene Marie's memory. And I've spent a lot of time kind of looking more about her and hearing from stories that have been posted. And the things that really stood out to me is that there's such power of a story, and little things can be big things. I have no disclosures to make, and I won't be discussing any investigational or unlabeled use of a product. As far as learning objectives and what we'll be going over, my goal is to challenge you in your thoughts, perceptions, and approach to patients with complex needs. I'll be reviewing costs to families that have children with complex medical needs, explore the sibling and family dynamics when there is a medically complex child, and I'll review the challenges in navigating complex care, palliative care, hospice, and also while being a practicing physician. So the rules are, this is going to be an honest dialogue. You're allowed to ask me absolutely anything without judgment, and my goal is to challenge you in your views and your practices. So while I love a good story, I would love to tell you a little bit about my family. So I grew up in rural Michigan, about a half hour north of South Bend, Indiana, went to undergrad at University of Michigan, then went on to med school in Arizona, where I met my now husband. He was a fourth year student when I was a first year. He had signed up for the US Navy, and I had committed to the National Health Service Corps to practice underserved medicine. There, he then started his residency at University of Toledo. We did long distance. Then I started my residency at University of Toledo. Then when he finished and started his fellowship at Cincinnati, I transferred as a third-year resident from University of Toledo to Cincinnati Children's. At that time, we had 1 daughter, Yasmin, and then it was time to do our government commitment, him in the Navy, me in National Health Service Corps. So we were stationed in Portsmouth, Virginia, and I worked in a strip mall in a clinic by myself and cared for children without any insurance for 4 years. It was there that we had Soraya and Lena, and then we moved back to Cincinnati. So as far as what we'll be going over today, we're going to review what it was like for me as a resident. We're going to go through the logistics of our life as a 2-physician household. Then I'll be going over emotional and social aspects and how that impacts us. As much as I love talking about my story, I have been able to gather voices of other parents. And these parents are physicians that have children with some sort of rare disease or a disease that is known, but is something that is off the path of neurotypical. I also will be reviewing our relationship with palliative care and hospice, and of course, there'll be time for questions. So first, thinking of me as a resident, and pulling up Epic, and I would pull up a diagnosis list, and I will see hypotonia, G-tube dependent, global developmental delay, hypoglycemia, GERD, feeding difficulties, long QT, mixed receptive expressive language, and other speech and language deficits. I'm putting myself under the bus here. I would be thinking certain things in my mind that I would never say out loud, and here I will share them. I would feel like the parents must have done something wrong to have an outcome and a diagnosis like this. I would feel like something must have been off in their history because I truly felt that there'd be something I could pinpoint to find a cause for an outcome like this. I truly felt that parents could have done something to prevent this. I realize now that that was just a way of protecting myself and truly believing that something like this could not happen to me. I would view the families, and especially their moms, as crazy. I would feel like they all swore like something was wrong with their child. Again, being on this side of things, I realized that these families, these caregivers are really onto something, that we as physicians need to do a better job of listening to our caregivers. So as far as our story, Sarai was born, spontaneous vaginal delivery, full term, nothing that came up in my prenatal history. When she was born SGA, or small for gestational age. This was different, as my first daughter was not. When she came out, she wasn't moving the right side of her body. She got whisked away to the NICU. She immediately started moving and then came back to me without any intervention. When she fed, I felt like she really got tired. I remember telling the pediatrician in the hospital about this, and I remember her telling me, "You just graduated residency and you've done this before. You know how newborns are." Fast forward to the 2-week appointment, I told the pediatrician, "I feel like she's making a funny noise when she feeds." Again, I was reassured, "Are you studying for boards? Because if I referred you to ENT right now, they'd laugh at you and they'd laugh at me." Fast forward, 2-month appointment. I needed to get back to work in full time with the National Health Service Corps, and I could not get Sarai to take a bottle. And again, I was told, "You're just so good at breastfeeding. That's why she won't take a bottle. When she's in daycare, she'll feed. There's no way she's going to starve herself." Fast forward, 4-month appointment. And at this point, Sarai was being force fed 1 ounce in a 10-hour daycare period. And I would nurse her all throughout the night. And at this point, she was officially failure to thrive. At this point, I was told, "Go ahead and give her solid food. You need her to gain weight." And I surrendered. I said, "You know what? I'm going to just do what the doctor says." So in this video is when she took that first solid food.
Daddy, little bit.
That noise is Strider. You look at her hair, she's sweating. So with this video, I sent it to the pediatrician. At this point, I didn't ask. I said, "I need a swallow study." And the way that things are scheduled, a month later, we got our swallow study, and it was then that we learned that she was aspirating. So now we have a child that's SGA, feeding difficulty, stridor, aspiration, poor tone, and we went from nobody being concerned to everybody being concerned. And we were whisked into 9 subspecialists. We got her G-tube at 6 months of age, and in this time, we had a full medical workup. We went from, your child probably has spinal muscular atrophy and won't live until they're 1. Your child probably has adrenal leukodystrophy. Your child probably has a disorder of neurotransmitters. And these diagnoses and the uncertainty continued. We went all the way to getting exome studies, which at that time was fairly difficult. We did an act of Congress to get a fresh muscle biopsy to look for mitochondrial disease. Everything was inconclusive. To this day, she's in 2 NIH studies and she continues to be undiagnosed. My point in sharing these aspects of this story is that it may have taken any other family so much longer. And this is how long it took us with 2 physicians. As far as the residents that are taking care of patients that are complex, do your best to not look visibly overwhelmed. At the same time, don't read through the checklist. So whatever computer system you're looking at and they have milestones on there, instead of asking specific questions that are on the computer, look at your patient, Ask the child and the family what they do for communication, mobility, and activities for daily living. Most importantly, ask how the caregiver is doing. Again, I'll put myself out there. I know as a resident why I didn't ask. I didn't ask because I didn't want to see somebody start crying. I didn't want to sit with them. I didn't know how to solve it. I didn't know the answers, and I felt ill-equipped. I remember being a resident thinking, when I'm an attending, I'm going to have so much more time, and that's when I'm going to do it. And come to find out, we don't. Currently, we have 15 subspecialists, and I can count on my hands how many times somebody has asked me how I'm doing. Logistics and how we do things as a 2-physician household. So I now work part-time. I work Monday, Wednesday, Thursday. My husband works Monday through Friday. I have a 10th grader in school all day, a 4th grader. Soraya's in 7th grade. Because she does not have a diagnosis, she does not have a treatment. However, what we do is therapy. She makes enough progress in therapy to continue, not enough to get released. So on Mondays, she has feeding therapy, physical therapy, Tuesdays, OT, Thursdays, speech therapy. We have a full-time nanny and a second sitter when it comes to appointments. If it's the pandemic or the summer, we have 2 full-time sitters consistently. Here are some fun pictures of us going to Disney World. So finances, I think this is something important to discuss. At the time of our discharge in Virginia, we were on a tube feeding schedule 5 times a day, as well as needing to warm up the bottle, then try to feed her PO. She had reflux. If she threw up, we would have to guesstimate and then gavage the rest. And so it really allowed for no sleep. And so thinking about how much a night nurse would have cost, it would have been $90 to $120 per hour at that time, something that we could not afford. I do think it's really important to know who qualifies for Medicaid in what state. While we were in Virginia, Medicaid would cover for any individual with a qualifying diagnosis, and it is not based on the household income. So ironically, we would have qualified for Medicaid in Virginia, but nobody told us because we were 2 physicians and we had the bias that we had a lot of money and didn't need the resources that Medicaid could offer. However, if we did apply for Medicaid and we were on top of it and had a college fund in Soraya's name, that college fund could be counted as personal assets against her. And so I really feel like we all as physicians need to do a better job of educating ourselves on Medicaid, as much as it can be quite tedious if we don't know who does and how do we help our patients. As far as how much it costs for therapy, we do have insurance, but our insurance caps at 45 visits per year. So if we are doing 4 therapy visits per week, that's 16 per month. That means in 3 months, we're about capped out. And after that, it's about $390. For feeding supplies, and we do pureed by G-Tube, it's $900 per month. And that's just due to the Kate Farms base, as well as the syringes and the G-Tube connectors. We also have a medical bed that costs $10,000. A 3-day EEG at Cincinnati Children's is $56,000. We have a $12,000 max out of pocket for our family insurance. That is never a problem to hit. The issue is there's so much that insurance does not cover. This is a healthy year where Soraya did not get hospitalized for anything. And just for maintenance of her care, that bottom number, the red number, that's the second to the bottom, that's $25,502.60 is a healthy year of how much we pay for her maintenance of care. Other considerations and how this has impacted us. As physicians, I feel like we have this concept of delayed gratification. And for me, it was, I will follow my spouse around while he's in the military. And then after that, my dreams were to move back to rural Michigan to be close to my parents. And at that time, while we were interviewing, and Soraya was still undiagnosed, but doing well, we realized that where we wanted to practice, they didn't even have all the subspecialists that she needed. In order to get her care, we would have to drive 3 hours in either direction. And so therefore we had to scrap our plans and come up with what would be more important. Would it be family support or would it be medical care? And then in re-looking at that list, where could we afford to live with a house that could have modifications if needed, not knowing what her future would hold? And here was Cincinnati, and that is how we ended up back there. We bought a house that could be modified. we bought a house that was in a school district that would be great for both neurotypical children and those with complex needs. And honestly, we then changed our career paths. It was in my final year at Cincinnati that I truly loved inpatient. And I thought to myself, I really want to be a hospitalist. Well, when we create plans and life happens, some of those things have to change. So emotional and social aspects and how this has impacted us. Can you raise your hand if you're a parent? Thank you. For me, from the moment that I was pregnant, I started dreaming of something. And it's not a gender, it's a path. It may be fleeting memories or future memories of them playing with their friends, doing a sport. I realized that subconsciously I created a plan. When I realized that Soraya was not going to be the child that I had planned for, it felt like death. I relate this process to grief, as I truly feel like I'm grieving the child that I had planned while I'm learning to love somebody new. And I did something really rude. I asked you guys who were parents. And I think that's because there is this idea that if you're a parent, that we share similar experiences, and that is not the case. It's that punch in the gut feeling of, well, if I don't have a kid, then I can't relate to you. And for me, I actually feel more isolated around other parents because our experiences are so different. And I feel even more isolated in that we don't have a diagnosis. Now, as far as what parents are concerned about, if you have a typical developing child, you may be worried about ear infections, teething, potty training, sports, colleges. If you have a child with complex needs, you may be worried about, will they ever walk? Will they ever talk? Will they ever verbally communicate? When will they die? And if they live, who will care for them after they die? And how do you set up funds to care for them? I put both of these on a slide, not because I think one section is more valid than the other. The point of this are both of these are valid concerns. These are both sets of parents that truly are concerned for their child. It also really reflects that it's your experience that shapes your lens on what is important and what we're worried about. You always have it tough until you have it tougher. At the same time, if you have two patients with the same diagnosis, please know that the parent's perspective coming into that situation could be very different. And as a care team, you will have a very challenging time to get everybody to see eye to eye if those lenses are different. My ironic position, I do well child visits for life. I cheer on every milestone. And I think in the first 3 years of practice, this was very hard for me. I would see a 1-year-old walk across my exam room and I would be so happy for that child. But then I'd go back to my office and I would sob my eyes out. And it was because I wasn't sure if my child would experience that same joy. Social media at that time was really tough. When people would post about being pregnant, when they would post about their child having a fever, and that's the worst possible thing that could happen. They post milestones of walking, talking, reading, you get the point. At the same time, when we're longing to connect and we're feeling isolated, the internet can be a nice place to find people. I first gravitated towards parent blogs, and sometimes I felt like there was a lot of anger towards physicians and a lot of the parent blogs, and therefore I pulled away from those blogs and found a physician group that has been really helpful in just having, again, a similar lens. For the sibling experience, I wish I could give you all a 5-day seminar on this, as this is an aspect that I have learned the most and has honestly been one of the most challenging. In this bottom picture, you'll see my oldest. She's 4 years old at that time, and she's watching Soraya do speech therapy. It was on that drive home that she asked me to roll down the window and throw her out. She said, "You don't need me anyways." That was my wake-up call. And age 4, we got her started in therapy, and she was diagnosed with adjustment disorder due to the fact of Soraya's medical condition. Fast forward, she did well in therapy. Soraya was doing well. We moved to Cincinnati. And I thought, she doesn't need therapy. We're all good. And then Soraya takes a toy from Yasmin at the age of 7. Yasmin pushes her down. Very typical interaction. The difference, Yasmin thinks, wow, my sister wears AFO braces, can barely talk, has a G-tube, and I just pushed her down. I'm the biggest jerk. I'm going to go in the corner and hurt myself. And that is when I realized that her experience is very different than what the child affected is going through, as well as what the parents are going through. At that time, we got her back into therapy. She got diagnosed with generalized anxiety disorder. Fast forward age 9, Soraya was in the trauma bay and subsequently admitted during a Thanksgiving holiday. I thought it would be a great idea for her to visit once she was stable. In that interaction, she was not ready to see Soraya connected to everything. And from that moment, has been diagnosed with PTSD from that. And it was at age 9 that we got her started on an SSRI. I make a point of saying this in this lecture because it was the most challenging thing to have my gifted, healthy child get started on an SSRI. So I just want to stress the importance of mental health when it comes to the family and the siblings. We do have some fun as well. In the top picture, my husband likes to do Soraya's YouTube changes every 3 months, and we make it a celebration. If the siblings hold hands, support each other, everybody gets a prize. In these pictures, you'll see Soraya wrapped up in a blanket. This was going to be the 3rd spring break that we would cancel because Soraya had an unexpected hospitalization. For the first time, I had the idea of dividing and conquering. And so these 2 sisters were going to go with their dad to go visit grandparents. In this bottom picture, you see Soraya getting her finger pricked. And I wonder how different it is in birth order and how different it is for a younger child coming into this world, having all of the medical equipment around them compared to my oldest, where everything was changed. As far as sibling resources, it's been really hard for me to find. There's one individual I'd like to point out. This individual is Nathan Grant. He did start a nonprofit organization called Siblings with a Mission. And that group is something that everybody can have access to. So I want you to be aware of that. My daughter found him at the age of 8. So that's the picture in the bottom corner. And he started the organization in high school due to his sibling. And they do an annual symposium at Cincinnati, but it's also virtual. And this year it'll be July 19th. This has been a wonderful resource for my girls, as well as a way for them to have a mentor on this journey. Another group that I just learned about is the Courageous Parent Network. I do wish I learned about them sooner, but they do have sibling resources as well. So please, please, please share these things for your siblings. Also, if you have families that are traveling for second opinions or away from their families, please acknowledge that. Please ask them how they got here and who is watching their children. When we were traveling for opinions and care for Soraya, this was a letter that Lena wrote. I love you so much. You are a star, and I will miss you so much. You will do great. We all believe in you. Love, Lena. She was in kindergarten at that time. One of Soraya's surgeries, first thing post-op she wanted to do is FaceTime her sisters. Marriage. I will never judge a couple that is actively fighting, yelling, or in the process of getting a divorce. I do feel like having a child with complex needs changes the dynamics of a marriage. I feel like if you are coping differently, or if we relate this to grief and we think about how people cope with grief, you're not seeing eye to eye, can be very challenging. For us, it's been great in the sense of it's a stronger bond. When we get new syringes or something approved by insurance, we high five each other. It's really silly, but for us, it works. Friends and family, I think this can be really challenging as well. Our most supportive friends have been those that are in medicine or have some understanding of the medical system. I think looking on the outside, it can be really hard to see 2 physicians having a child that's undiagnosed. And it's really hard to not have a diagnosis. And it's really hard for other people to be in the gray with us. It's like friends and family don't know what to say or how to act. I also think it can change the dynamics of your relationships with people if we could imagine for a moment that something happened to you where you needed help, like real help, not just like for a day, but for a long time, maybe months, maybe years. Who would be there for you? Who would help you? What happens if the people that you imagine were going to be there for you are not? How does that change the dynamics? So an example of that is I do believe that my husband and I would dream of going away for the weekend and having grandparents watch the kids. What if grandma's not cool with the G-tube? How does that change the dynamics of your relationship? So I'm going to make a shift in thinking about how we monitor for clinical changes in a child that's undiagnosed. For Soraya, we knew that she had something metabolic. When she was doing a little bit of work, her heart rate would go up and her blood sugar would drop. The second panel is a testing called COSMED testing, and is something that is done at Cincinnati Children's on a research basis. It got started first in Navy SEALs to look at energy expenditure. Then it went on to the NFL where they did fitness testing. And at Cincinnati Children's, they're doing this type of work in kids with cerebral palsy. So for Soraya, they would attach her to this monitor, and about every 6 months to a year, we would do a 6-minute walk test and see what her resting heart rate is, how much energy expenditure she had. So in this picture, her resting heart rate is 127. It was around the time of COVID, about 3.5 years ago, that everything was on virtual visits, and we realized that Soraya was getting fatigued. Very vague complaint. And with that, we did a telehealth with our pulmonologist, and we couldn't quite figure out what was the cause of the fatigue with so many other factors involved. So we were told to get a CT scan of her lungs. Well, we did that in person, and the tech told her to take a big breath in. It was at that moment that I realized her chest wall muscles weren't moving. Went home, took a video. Sure enough, there was no chest wall movement. Similar story in that I sent the video to the pulmonologist, and he said, let's get a sleep study. We've had numerous in the past. And while we got in, sure enough, she was hypoventilating secondary to chest wall muscle weakness. This was a huge change after 9 years of kind of progressing, doing well. And so it was at that time that our team referred us to the NIH. It's funny that I include this here, but I think this really shows how many hats we wear as physicians. I was excited to go to the NIH during COVID. I was so grateful for everything that they do. We got to spit every day to make sure we didn't have COVID to exit our room. I mean, the science, it was everywhere. It was like I was at Disney World and I was a kid. There was worldwide team all trying to help us, all trying to figure things out. This shows you Soraya's personality. She hated wearing the outfits for the MRI. There were muscle testing. It was along this time that she was about to start 4th grade. And while we had a wheelchair for longer distances, she told us, I'm so tired. I think it's time now that I use a wheelchair for school. Another thing that never dawned on me, what if your child went to school since kindergarten with the same people, but then shows up at the bus stop with a wheelchair? How do you react to the questions? How do you respond? And so with that, I went ahead and created a video to kind of help families and students understand. So I may need some help loading that.
Cover me in sunshine, shower me with good times.
My name is Tasha Faruqui. My grade is 4th grade. I did not break any bones. I have a wheelchair because my body gets really tired really easily. Some of the fun details about my wheelchair. It can go really fast. It can go really slow. And there's different types of speed. I like that I picked it out. It's glittery and pink. I love the color, but it's not really my most favorite. I just picked it for fun. I like most about the wheelchair because it helps my body. It makes me feel like a bird. I am most proud of that I know kids can. On the children's website, I'm on a bus and I'm on the ad. It's just people looking at me, that's all. That makes me nervous and scared. I want them to know that I'm not scary. You can always come talk to me. Just let you know, guys, don't be scared. I, of course, can walk and run, can do all those normal stuff. I like playing with my sisters. It's like playing like a chase game, tag game, and basketball. What I like to do is hang out with my family and making friends. I want you guys to know that you can talk to me if there's any questions or anything.
Great. So with that, I'm going to shift into what other physicians would want you to know, knowing that I'm giving this lecture. The need for respite services, I wish it could be addressed at doctor's appointments and applications handed out. The parents probably know more about their child's condition and definitely more about their child than the doctor, especially in the case of a rare disease. Therefore, ask the parents what they think. Really think about the daily heartbreak the family goes through. Place value on the child's life just like all other children. They may be so behind, but that family is proud of that child. Be aware that caregiver stress rates are high. Discussing respite is key. Do not be intimidated by the child's illness or the perception of the family suffering. Engage the families and play with the kids just as you would with more typical families. Treat them like regular human beings. Give parents, caregivers permission to get respite so they don't feel guilty. Make sure you ask about neurotypical siblings, their adjustment to the special needs child, and find ways to support siblings who often live in the shadow of the special needs child. Don't just give a diagnosis and leave us out there. Hook us up with info on services via caseworker should they not have the time. Trying to understand all my little one is eligible for is hard. It's a scary and confusing time, and it breaks my heart that as an educated person, I define most of the resources and do the research myself. What do other parents do that don't have medical degrees? Knowing about Medicaid eligibility requirements and waivers available for kids with special needs in your state would be very helpful. If you don't know yourself, knowing where to send families is important. I have noticed that state Medicaid websites are confusing, even to me. In many cases, the child may qualify for Medicaid based on his or her disability alone, and parental income is not counted. This can be a huge help for the family and can pay for some therapies that commercial insurance might not. Avoid platitudes like special kids get special parents, and kids with X diagnosis are always Y. For Down syndrome, this is some version of happy, outgoing, cheerful. Recognize that the family is probably mourning a little for each missed milestone, and that watching other kids do things like join Boy Scouts count as milestones. Delight with the family in all the things the special needs child can do. I have wondered why people use platitudes, and I think it's because of discomfort. It's uncomfortable to see someone struggling. It's hard to just sit with them in it. A regimen that seems great in the hospital may not be feasible once home. For example, G-tube feeding schedules every 3 hours over 30 minutes to an hour each. Parents need to sleep at some point. It's fine if you're in the hospital and nurses are providing care, but at home, it's physically impossible. Before I had my son, the kids and the moms with the big binders were the most intimidating by far, and the last patients that I wanted to see. The moms seemed aggressive and demanding and crazy, and now I know why. Because it's extremely difficult to be a parent of a child with special needs. It's a constant battle with doctors, teachers, therapists, counties, states, insurance companies, and school districts to get your child the care and services that they need. Nothing is easily defined or spelled out for you or even understood by experts. It's a path you have to pave, oftentimes on your own, and it's devastating emotion. The social issues are complex, and being a special needs mom changes your relationships with your friends, your family, and the world at large. Until you're in it, you can't understand. And now the patients with the big books and their beaten up moms are my favorite. So I've taken you on a journey, and it was very intentional, a journey where I first realized that my child has a disability. And then I realized they may never have a diagnosis. And I learned how to accept being in a stable position and accept that she's undiagnosed. Unfortunately, as we started her on BiPAP ventilator back 3 years ago, there's been a progression. That need for her vent has increased. There was losses, increased weakness. And with that, we're all done with therapy. This is a picture of her and her therapist that she has been with since she's 3, and that's her last day of physical therapy. Not because she graduated, but because she was too weak to continue. This is her last day of school. With all of this grief and all of these losses, it was then that we started with palliative care. And honestly, what got us there was pain. We first asked for their help for pain management. Then we wanted massage therapy and realized that the hospice team had one. And so our involvement with palliative care and hospice is one that was parent-led and parent-requested. I just put this out there because I think it's one of those things where I wonder how these relationships are formed had I not asked. I don't know when the right time is. We also chose to have our patient, Soraya, informed along the way of all the things we were doing and why. And with that, Soraya does know that she is dying. She got to make the decision of whether she wanted to have a trach or not. And with that, her sisters know that she is dying, and we now have a shared experience. This space of anticipatory grief is one that I had never thought of before being in this position. And in looking at what that definition is, it's the feeling of grief that occurs before a loss. Rather than grieving the loss of a person, anticipatory grief might be better understood as grieving the loss of experiences, possibilities, or imagined future together. And I do feel like that really describes where we're in ways that I've been surprised that hospice has been helpful. And I'm only sharing this in case it's helpful to you to know what are things that are possible. For us, they've helped us with sibling activities. They've helped us with communicating with the siblings about what is happening with Soraya at an age-appropriate level for them. They've helped us utilize and create family meetings. They've even come out to school meetings when our school wasn't quite receptive to the ideas that we had for the accommodations that Soraya needed. They check in with our caregivers. They make sure they're doing okay as they care for Soraya as she's actively declining. They've helped us with spiritual leader connections, as well as been open for philosophical conversations. I think while I've had a very positive experience with hospice and in complex care, there's always room for improvement. And for that, I'd like to share my wish list. My wish list is that with our 15 subspecialists, I wish there was better communication. I wish there was someone to tell me, how are others in this position doing this life? Please connect me. How can we connect to one another? I know we have the barriers of HIPAA. How do I know what I need? How can I request what I need if I don't even know how to live? And I think one of the ways that we have really learned from our experience is that from the experience of Make-A-Wish. And that was one of our first referrals with palliative care. And in May of 2022, Soraya got her wish and she surfed in Hawaii. It was that moment that we realized we can do it. Like, we had never traveled with her ventilator, her cough assist, her glucose machines and monitors, and her pureed by G-tube, a blender, you name it, we brought it. Sand wheelchair, they even arranged that. It all could be done. And it was a beautiful way of learning how to live. That maybe while the lows are low, we really try to live high. And with that, we created bucket lists and we went for it. And so in this slide, this is a fundraising event at Cincinnati Children's with Andy Grammer, and our girls got asked to go on stage. And of course they said yes. Soraya got to experience her first Bengals game. She wanted to swim with the dolphins. And of course, on her bucket list was seeing Taylor Swift. My husband could not get a ticket, so he was Joe the driver and still played the part. We went out and found Andy while he was touring in Ohio, and we created a motto, and you see that on Soraya's shirt. It's called "Suck the Joy Out of Life." Yes, it's an aggressive term, but that's because we have to aggressively go and find it. And if you don't know his music, please find him. He is the kindest person. This night of the concert, he dedicated his song to Soraya. The other thing I want to share is never say never. One of the promises that my husband and I made to each other is, while we knew we wanted to have children, we 100% were not going to have pets. And over the past 3 years, we have 2 pets and a dog. With this kind of newfound way of living, we do a lot of work with Make-A-Wish, and they are an organization that is near and dear to our heart, really just setting an example of how we can live and what is possible. Earlier this fall, Soraya and the girls had asked to go back to Hawaii, and we were really nervous about that. Soraya has changed a lot. The trip was not going to be the same as it was, and we didn't want them to be disappointed. We asked our care team, and they said, go now. So we went, and it was very different. You see Soraya, she actually never left her hotel room, and she slept. I did find a ukulele player who came and gave her a lesson, and that was the highlight of her trip. We had her 2 sisters and our caregiver, they surfed in her honor. In other ways that we're trying to fill these bucket lists, but in a way that can be modified. Most recently was her 13th birthday, and she's always wanted this huge party, but she knew that she was too tired. So this year, she decided she wanted to hang out with a drag queen and go shopping. I will tell you, I do not know one drag queen in Cincinnati, but I did what I could, and I just want to thank Broccolia Spears for showing up. For saying, hey, I know we don't know each other. Can you come to my house, hang out, and even go on a little shopping trip to buy makeup? So curveballs along the way. I was under the impression that when bad things happen, that there's a limit, that really nothing else can happen. And unfortunately, also this summer, I found out that I tested positive for a cancer gene called PALB2. And with this gene, it puts me at risk for breast, ovarian, and pancreatic cancer. And thinking about Soraya and thinking about caring for her, I decided to get a bilateral mastectomy. And so just this past December, I went ahead and went through with that. My point in sharing all of this is that the lives of our patients can be very challenging. I appreciate my care team and my breast surgeons for hearing me when I told them about Soraya, for hearing the urgency of wanting to get this taken care of so I could be there for her. With all this, I created an online community. This is a public account that follows our journey, the day in and the day out, really to create a sense of community for those that are in the space of anticipatory grief. Please stay connected. This is my website. While I've created this online community, I've also written a book. The book is really sharing about this journey and really helping to find other ways so other families don't feel as isolated. And I want to share that all proceeds of the book are going to organizations such as Make-A-Wish and Cincinnati Children's. None of it is for profit. All of it is to share our stories, to help our physicians, and to help our families. And with that, I open it up to questions.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.